So now we'll officially start. So this is Mike Regas. I'm the chairman of the board of directors and the medical advisory panel for ADA. I'm a pharmacist and I'm a longtime IVIG person. And I'm not in Charlotte, I'm in San Diego area, California. I'm happy to moderate this evening's hybrid meeting with Realo Specialty Pharmacy for patients at IV and sub-QIG. ADA's mission is to provide support and advocate for greater than 25 million Americans with immune disorders. ADA works to promote research and create better awareness of immune disorders. So I'd like to introduce our two speakers tonight. First, Will Holland, PharmD, is the Director of Sales and Business Development for Realo Specialty Care Pharmacy, obtained his Doctor of Pharmacy from UNC, Eshelman School of Pharmacy, completed a residency with the UNC. He's an Immunoglobulin Certified Pharmacist with a strong passion to improve the lives of each of his patients. So I'm glad to have you here with us tonight, Will. And with him is Brady Hecht. He's a UCONN School of Pharmacy alumni who completed residency in specialty pharmacy with UNC. He has 4 years experience at Realo Specialty Pharmacy working with patients receiving immunoglobulin therapy. So gentlemen, I'm going to turn it over to you. I'll let you control the screen. And if any weird things happen or loss of connectivity or whatever, God help us, but I'll do my best to make it good, and please proceed.
Okay, thank you, Mike. Like Mike said, my name is Will, and this is Brady. We want this to be interactive. We do have a couple guests here live with us, and then of course a handful virtual as well. So if you do have questions, please feel free to ask those at any time. We'd love to stop and chat about it. But otherwise, we'll get started. So we came here tonight to talk about immunoglobulin. You know, is it right for me? Learn a little bit more information about it. Get involved in community events. Get involved in disease state education. And so let's get started. So just a little disclosure here, Brady nor I have any type of financial relationship or commercial interest to disclose. Another small disclaimer, a lot of the information presented is factual from studies that are given or package inserts, but as always, please consult any type of healthcare professional before making any decisions that may affect your health. So tonight we want to learn about IVIG and sub-QIG. So really understanding immunoglobulin, or IG as they call it. What are the standards of care? What are goals of treatment depending on the type of disease state you are treating, type of condition you may have, and then understand the role of a specialty pharmacy and a specialty pharmacist. So why they're important, why it's very important to make sure that you have a great specialty pharmacy advocating for you and your condition, and then talk about some financial assistance options, as immunoglobulins are often very high cost medications, and we want you to be educated to know that just because of a high cost, we don't want that to be a burden and a barrier for your treatment. Review some lifestyle and other non-pharm factors that may affect your medical condition. So just a basic overview of the immune system. I feel that this is a good way to kind of kick off immunoglobulins because they're also known as antibodies. So when you're thinking about an immune system, you have two types. So one will be the innate. This is the one that is ready for immediate action. It's your skin, it's acid in the stomach, it's neutrophil, macrophages. So it's very non-specific. So any type of virus, bacteria, something foreign, it doesn't matter. It will attack and try to get rid of that. Where then you have the acquired. It is more specific. These respond more slowly. This is where your white blood cells come in that make B cells and T cells. And the B cells are responsible for immunoglobulins, for your IGs, for your antibodies. When you think about an acquired or specific, think about a vaccination and when you get a vaccine. So IGs are responsible for killing your viruses and bacteria. These are really more focused, like a vaccine would be. So how does a vaccine work? Well, these are memory B cells are created to remember. And so if you look at the figure, there you can see on 0 would be the day that you get the vaccine. And so that's the first time you get exposed to this type of antigen, or let's just call it a virus or bacteria. Your body peaks some antibody blood levels, and it takes around 14 days to build up that full immunity, as they call it. And then that second bump is that second time you get it, not necessarily 28 days later, but the next time you get a cold or you get the flu after you get a flu vaccine, you have a large response, primarily IgG. And so the main response there is from the memory B cells, and it is an antibody response that is built to be specific to that particular antigen, virus, or bacteria. B cells lifespan, they do vary, so that's why you may see some boosters on some of these vaccines that we get. Children, of course, get boosters because their immune system is not really built at 100%. You know, that takes years, so that's why they're continuously getting boosters along the way. I want to go into just a brief history of immunoglobulin. At this point, we are looking at over 80 years of use. So there is a lot of history there. The first one was introduced back in 1952 for a primary immunodeficiency disease called X-linked agammaglobulinemia. This one was an intramuscular treatment. Intramuscularly, it is a large amount of Ig and a small amount of diluent. And so when they injected that, what they found is it was extremely painful. So patients didn't really want to use it. It didn't work as well. They weren't getting the full effectiveness. Fast forward 30 years, the first IVIG became available. So it took 30 years kind of from that first usage to really get more of the IVIG that we can see today. And then about 25 years later, we ended up with subcutaneous IG. So that came the first time that a patient could self-administer without a healthcare professional in the comfort of their own home or you know, wherever it may be. 8 years later, we had facilitated subcutaneous IG. There's only one on the market now that is HyQvia. We'll kind of go into that a little bit, but essentially that mimics, from a therapeutic standpoint, IVIG. It's still one that can be self-administered rather than the IV is given in the vein, has to be done by a nurse or other healthcare professional. You have a question? Yes.
I have a question, sorry. Is there a significant difference between an IVIG and an SCIG, other than the way they're administered?
In terms of effectiveness?
Yeah.
Great question. We have patients ask us that all the time. There is not. It's really more, both are proven to work effectively in the disease states that they're approved for, and then some off-label uses. Often it comes down to the patient's preference, the patient's comfort, side effects that may go along with it, and cost burden. And so there's a whole picture that goes into it. But from an effectiveness standpoint, they are all immunoglobulin, and so they are working to build antibodies in the same manner.
Thank you.
You're welcome. So how do we get from how does a manufacturer make IG? How do we get the infusion product that we use often? It starts with plasma, and it starts with a lot of plasma. And so one lot of immunoglobulin will have to get from 10,000 donors. One of the reasons that they go with 10,000 donors, you just want a lot of broad antibodies that are found in the general population. And while that is important, is because when you are treating for a primary immunodeficiency, you are replacing antibodies. And so that person has an immune system that is dysfunctional. It doesn't fight off infections like a normal immune system may. And so what you want is common antibodies that are found in the general population that the patient is in. That is another reason that all IG products licensed in the US, they have to be made from sourced plasma that has been collected in the US. And so if you're a US patient receiving IVIG or sub-QIG, you can rest assured that all the plasma was collected and manufactured in the US. And that's for the same reason. So for the disease states that we have in the US, we want to be able to treat those. Now, on the flip side, because we are a larger producer than most other countries, we do ship some of our plasma and IG to other countries, often some third world countries that need it. They don't have the manufacturing facilities or plasma collection centers like we do. And so when you think about IG therapy, you kind of break it down in two categories. You break it down into primary immunodeficiency and autoimmune. Primary immunodeficiency, there are over 450 different types of primary immunodeficiency. Some common ones are hypogam, common variable immunodeficiency, CVID, and a few others. Those are probably the most common. The main goal here is to replace the antibodies that your body can't make. So we want to increase those IG levels. I say a simple replacement therapy, but from a mechanism standpoint, you can't make the antibodies, so we're adding new antibodies in. Autoimmune is a little more complicated in the way that it works. Some common autoimmune are seen in the neurology conditions, so CIDP, myasthenia gravis, some rheumatoid conditions such as dermatomyositis. The goal is to limit the malfunction of the immune system. So when autoimmune, your body is attacking itself. From a mechanism standpoint, so how does it work, is very complex, and honestly, they don't fully understand the complete mechanism. The belief behind it is that the immunoglobulin that you are infusing into the body is binding to the receptors, forcing the bad antibodies, if you will, out. So that's kind of it's kind of overrunning the bad with the good. These are the FDA-approved indications. IG is often used off-label. Some of the common ones here are ones we discussed. So primary immunodeficiency, you can approved in IV and sub-Q, CIDP, all the way down to dermatomyositis. Some of the off-label here, stiff person syndrome, multiple sclerosis. It was even used during the pandemic for COVID patients as well. I'm not going to go through this in complete detail, but these are the list of the branded products that are out today. All of the IG products are branded, not generic. On the IV side, when you're looking at a 5 or 10%, what that simply means is 10%, 10 grams and 100 milliliters. So when you're thinking about from a volume perspective, how much are you infusing? If there is 10 grams, you're infusing 100 milliliters. And so if it's a 5%, you double the volume. And if it's 5 grams, or excuse me, 10 grams, it would be 200 milliliters. So when you think about infusion times, the more volume, the longer it may take. So those are factors that we consider when we're looking at different choices. On the flip side, when you think about a subcutaneous product, it is 20% is the majority of them. And that would be 10 grams and 50 ml. So you're actually reducing the amount of volume. That is a big reason that your body is able to absorb it, and we're able to go into the subcutaneous route, which is right under the skin rather than into the vein. I will have some asterisks there on the GammaGuard, Gamunex, and GammaKed. They have a 10% that can be IV or sub-Q, so they're unique in that way. The HyQvia is a sub-Q product. That's the one that is a facilitated subcutaneous. It is also a 10%, and it does mimic more of an IV dose, and we'll go into that, and I'll show you guys. So routes of administration. Of course, there are pros and cons to IVIG versus sub-Q, and it really does come down to the patient. I want you guys to keep that in mind. It's all about preference of what you want, what makes it make sense for you. So some advantages of IVIG is that it is less frequent. Often it is given every 3 or 4 weeks, depending on the diagnosis. And the first IV was made back in the 80s, and so it does have a long profile, risk mitigation. It has been studied for a longer time, so it is well known. Patient adherence is often higher, so the main reason behind that is that next bullet. You do have a healthcare professional with you giving that infusion. You are not self-administering that, so you may be getting it in a hospital, a physician office, a standalone infusion center, or in the home setting. But a nurse or a healthcare professional is always with you, and as a result, usually that means that the adherence is higher. The disadvantages, it does have to go into the vein. So if you are hard stick or you have poor venous access, this may not be the best route for you. Oftentimes, well, not often, but there are some cases where you have a patient who has IVIG and has had it for extended period of time, and it's just very difficult to find a vein. And so they can't really get the immunoglobulin started. And so that's when you may want to consider going to the sub-Q route. There are some side effects with anything, but more so seen with IVIG, and that's because of the systemic side. So because it's going to the bloodstream, it is going through the organs. It's not being bypassed as it would be with sub-Q. Also, it has a rapid absorption, and so what that means is that as soon as you get infused, you do have a peak right away, and you'll see that on the next screen. But the peak causes a lot of these side effects, and so it's a large amount of immunoglobulin being infused right away, and then it slowly trickles off over time until you get to a trough. Pre-medication as a result of these side effects are often required. Yes, sir.
I do my IVIG sub-Q.
That's right. So
Okay.
So you're
yours is sub-Q.
Yeah.
Okay.
Yes, sir.
I did have one question about that. I've always done it here. Okay. Are there other areas I can use?
Yes, sir. And we are going to get into that.
Okay. Good.
We can talk about it now. So the question was, what areas of the body could we also infuse with sub-Q? It's stomach and top of the thigh, and then in the back of the arm. And Brady's going to do an excellent job.
Also, you can do just around in the back as well, but it's really, you need a helper here for that.
Okay. Sorry to.
Oh, no,
No, it's a great question. Great
absolutely.
question.
Some of the advantage of the sub-Q is that it infuses into the fat tissue, not into the vein. You are able to give it self-administered. That makes it more convenient a lot of time for patients. It makes it flexible. If you have to travel, if you need to go somewhere, if you need to take it with you, if you need to do it at work, it's something that you can do. There are smaller infusion volumes. So we talked about the 20%. So for the same 10-gram dose, you're getting half of your IV volume. As a result, it does allow for more gradual absorption into the areas on the stomach or the thigh, and a steady state. So you're not getting these large peaks and troughs. You're getting more of a kind of a steady level. So no side effects. You don't really need extra pre-medications. Disadvantages, it is a little more frequent. So with sub-Q, it's often every 7 or every 14 days, depending. Patient adherence may decrease. I know for me, even though I'm a pharmacist, I forget my multivitamin every day. We try to take it, but sometimes as a result of that, adherence goes down. It may be day 8, day 9 instead of day 7, those type of things. There are a lot of great helper tools out there today with apps, setting alarms and different things to help with that. So that's not as big of a problem as it used to be. Lack of direct monitoring. So with our IV patients, we are having the nurse go into the patient's home. They're doing vitals every 15 minutes, writing up a full clinical nurse note, sending that back to the pharmacy. We review that to make sure there were no issues. We don't really get that with sub-Q. It's when we're doing our monthly calls to check in on the patient, we're asking these questions, but it's not as frequent as it is when we get it from the nurse. Reactions are not the big systemic reactions, but more localized. So where you infuse. So is it you can get the reactions in the stomach or at the top of the thigh.
Is that why you were asking?
Well, I have an issue with the infusion. I balloon up with the liquid. Okay, and itch.
Mm-hmm.
I don't know if it's a result of the skin swelling up on that infusion. It goes away. I mean, it's usually a day.
Okay.
I do balloon up with that liquid.
Okay. I will get to that. That's for sure. I will definitely get that one for you.
All right, super.
Yes, sir. So this is a good illustration of what we just discussed with the IVIG and sub-Q IG kind of peak and trough levels. So if you look at day 0 here, that's when the infusion is given, and you can see that high peak. You can see that it's substantially higher, and this is just a model, but substantially higher than the sub-Q. And then over around 21 days to 28 days is the half-life of an IG, so how long it's going to last essentially in the body, and it slowly trickles down. Whereas sub-Q, because it is every 7 days, in this case, that's what those red dots are, you can see that it is a more consistent dosing. So when you think about these type of medications, they are expensive, as we discussed. They are complex. They do have side effects, and it is very important, once again, to talk about what the patient wants in this therapy. And so the role of a specialty pharmacist or specialty pharmacy are these main steps here. It's the initial assessment, picking out the right selection. Which brand do we go with? Do we go with IV or do we go with sub-Q? What will the insurance pay for? That's where the benefit investigation goes in. What have we tried and failed? Does the patient have kidney disease or history of migraines, or is it a geriatric patient versus a pediatric patient? You know, there's a lot of things that kind of go into this therapy selection that the pharmacists work with the provider, the doctor, and the patient to discuss. Getting patient access. So because they're expensive, insurance has always put a barrier in place. How do we get this thing approved? And so what we do as pharmacists is we gather the clinical notes from your provider. We gather any labs or studies that have been done, write up a nice little letter of medical necessity and submit that and get it approved by the insurance company. We're very good at looking at what is on formulary, what the insurance requires, and getting it right the first time. One of the most important things I'll tell you, whichever pharmacy you're using or provider, you want to get it right the first time with the insurance, because then it's just an extended process and a lot more hoops that you have to jump through. Once we get an approval, we're looking at the financial assistance piece, looking at co-pays, how do we get those covered, and then first infusion. And so this is finally we're getting to where we can actually get the medication delivered to the patient, get a nurse to either give the infusion or train on the infusion. And so giving the patient the tools to succeed, discussing the medication, discussing what supplies are going to be needed, discussing the nursing, you know, how often will the nurse come, how often will the nurse follow up, what can you expect from your nurse, what can you expect from your pharmacy, and then getting you guys connected with community resources. Ongoing assessment. So we don't just stop at the first infusion. While that is great, it's very important to get you started. Really, the progress starts after each infusion, right? So making sure that you are responding to therapy. Is the medication working? Are we hitting that goals of treatment? Are you improving? Sometimes you may not feel the improvement, especially maybe if you have primary immunodeficiency. We're treating to get to a number, but what we're really treating is to prevent infections, prevent hospitalizations. Some of the neuro disease, you know, patients can feel symptomatic, you know, their symptoms improve, their better health, their mobility increases. Those are the things we're looking for. And then infusion optimization. Are we able to decrease that infusion time for you? Are we able to give you one less needle stick or a couple less needle sticks and get to the same goal? You know, those are things we're speaking about. And then side effect management. Making sure that there's no therapy that will, or side effect that will stop therapy for you. And then your overall patient well-being, you know, checking in, making sure that you are improving. Your quality of life has changed. That's what we want to see. And Brady is going to break all of these down in a lot more detail. So I'll let him go. Thank you, sir.
Excellent. So I would say my general role here at Realo Specialty is to do a lot of patient intake. I spend most of my time reviewing chart notes, reviewing new patients for submitting all of this information to the insurance companies. And then ultimately, once I get these approvals, walking the patients through the rest of the process of explaining expectations, working on financial assistance and things such as this. So how do I choose the best treatment options? Sometimes a doctor will send me a patient who has already been on a product. We're not moving you off of a product unless there is a reason you've had a reaction, you want something new in your life. We may move you from there. You're going from IV to sub-Q. So ultimately that could be a product switch. But generally speaking, if all things are considered equal, then we're looking at you as an individual patient. You could have various underlying conditions that might make me push you one way versus another. Patients who have very difficulty controlling their blood pressure may not be right for IV therapy because we're putting a lot of liquid straight into the vein. If your blood pressure gets too high during an infusion, that's a stroke risk. So all little reasons like that clinically where we might try and guide you one way or another. There's just a lot of small variables that we take a look at, and it truly is individual. I mean, according to the Immune Deficiency Foundation, all the patients receiving both IV and sub-Q IG it's about a 50-50 split, and that really is just dependent on patient lifestyle. So as we've said, you want to just do a once monthly treatment, you don't mind having the nurse coming into your home once a month. That's great. You feel like you want to be extremely independent, you want to just do it once weekly, maybe half hour to an hour a week. Sub-Q sounds great for you because you like to travel to Europe and you don't want to find a nurse over in Europe to help do your IV infusion for the month while you're on vacation. So a lot of different little reasons why we can choose between one or the other. Financial assistance, of course, is key. A lot of insurance plans do a great job of covering the bulk of their payments, but what happens when they don't? For commercially insured patients, we have manufacturer assistance ranging in the multiple thousands of dollars, sometimes $5,000 up to $20,000, depending on what the individual manufacturer is offering at the time. Using this, of course, to cover copays for anything that you might need. Otherwise, when it comes to Medicare patients, if this is Medicare Part B, we're often looking at patients who do need a supplement to help cover that 20%. These national organizations can still help cover for those 20%, but if you're a patient who has Part D as in dog, then you won't be able to get this direct manufacturer assistance. So in order to have a different way to cover some of those copays, I utilize financial assistance sources such as the PAN Foundation, the Assistance Fund, HealthWell. All these listed below are great resources. Most of the funds come from just generous individual donors that you could log on right now and go make a donation, but I would say the bulk of them do come from these manufacturers who utilize that as a way to say, we've set aside money that goes towards commercially insured patients and to make sure that our Medicare D and B patients have additional coverage as well. Then they place it into these other resources. And of course, there are a handful of free drug programs, usually the stipulation being that they want you to be uninsured and to not have been on their product before. So if you've been an insured patient who's been on something like, let's say Octagam, just to say a name, you've been on Octagam before, you may not be able to qualify for their free drug program. However, if you have never been on one of these products, regardless of brand, you can often apply and then they'll help you get insurance coverage in the meantime, is ultimately the goal. This is just a list of a handful of helpful community resources. Of course, we've got ADA up top here. Some of these as well, just very specific to different disease states, whether primary immune being a nice general immune disorder foundation as well, to see just a lot of different resources and kind of combine some of this info as well. It's always great to get different pieces and tidbits from these different resources, because if you just stick with one, you might be getting just slightly varied opinions that could help you out. Some more specific, like the GBS CIDP Foundation, covers a lot of neurologic disorders with the focus on those two as well. So just links here for you to take a look at in your free time. All of them I use frequently for patients. And now I'm going to get talking a little bit more about some side effects here. This is a general list. I'm going to talk about all of these more specifically as well. So some of the common side effects being these headache, flu symptoms, fatigue, issues like that. Of course, there are these less common, more severe side effects that we have to know what to look out for, but the odds of these actually occurring in a general patient population are very low. And of course, just to state this, the FDA has a black box warning on all IG products for thrombosis risk, so risk of clotting there, and IVIG specifically can affect your kidney function as well. So this specific to IVIG, headache, extremely common, probably the most common side effect that I speak about when it comes to an IV patient. It's really related to hypertension, and it also can be related to fluid intake as well. So from a blood pressure standpoint, if we're going too fast with the infusion, it can just cause your blood pressure to spike and ultimately result in a significant headache. Also, if you're significantly dehydrated, that can also lead to this headache feeling as well. Most patients will just be fine taking a Tylenol or an ibuprofen as a pre-infusion medication to help prevent this. However, if those simple solutions don't work, we can try altering your infusion rate. We could add some pre-infusion saline for you to help increase that hydration ahead of time. Maybe there might even need to be a change in your blood pressure medicine if that's truly the underlying cause. I've had some patients who they have a baseline blood pressure med they take, and then there's a more short-acting one that they take just before the infusion to help manage that. So there's a lot of different ways that we can work around this headache. It's extremely common and also fairly easy to fix. Next would be the dermatologic reaction. So as you can imagine, you're spending a couple hours with this catheter sticking out of your arm. Some patients are going to have, a reaction to that, and ultimately it can develop into something more serious that looks like a larger rash or hives that's more akin to a true allergic reaction. And if it were to get that serious, you would ultimately stop the infusion, utilize various protocols such as taking additional antihistamine like a Benadryl, for example. Some patients who frequently experience this sort of issue might add on a steroid such as Solumedrol as a pre-infusion strategy to help prevent this from occurring in the first place. Next here we have flu-like symptoms. So what does that mean? That's some of the chills, the rigor, the shaking that can occur here. This can actually happen hours to days after the infusion. It's not uncommon for someone to go to bed after the nurse is gone for the day and say, I'm feeling great. And you wake up the next day and all of a sudden you've got the chills. I had a patient I spoke about this morning who had that exact same side effect, said that she was sitting on the floor because the floor felt cool and it was making her feel better, and she had these flu-like symptoms. And so, what can we do to affect this? Often related to infusion rate. Again, pre-medications with these steroids or the Tylenol are really the best way around this. It's also something where if you are continuing to experience this, maybe it's something that just hits you for the first time. And that is the case with a lot of patients. First time patients experience this, and it goes away after the first couple. Your body really gets used to these infusions. But if this is something that continues to affect you, then you could consider switching brands or changing to a subcutaneous therapy if necessary. So now I'm going to shift over a little bit here and talk about some subcutaneous related reactions. As Bill had asked before, what are some of the sites that we can use to infuse subcutaneously? Most patients are aware of that stomach, that 4-quadrant breakup on the left and right side of the navel there, and the top of the thigh, the top inner portion of the thigh, as you can see on that left side picture of the body. On the arms and that small of your back there, and some of that subcutaneous tissue just around the back, those are meant to be assisted infusion sites. So if you have someone who can actually place those for you, that's what the manufacturer says, is that it should be done by someone, not the patient. I'm sure, as you can imagine, it can be a little bit difficult. I would have some flexibility issues trying to reach around to my back and reliably insert these needles appropriately. So it's truly best if it's just you as an individual to stay with the stomach or the thigh. So one side effect that is not extremely common but extremely easy to fix if you do experience it is infusion site leaking. This is most commonly related to too much liquid getting underneath the infusion site, and by too much under, I mean you've got 50 milliliters of liquid that we need to distribute for a 10-gram infusion patient. So if we're using a 2-needle set, that's 25 milliliters, and you branch out, so on and so forth. Depending on the amount of subcutaneous tissue you have, you may not be able to use a smaller amount of needle sets. So 2 might be too little for your particular body. We really need to talk about what are you absorbing. A first-time patient doesn't absorb this medication as thoroughly or as quickly. So it's something we need to consider, that maybe it's going to be best if you're a higher dose, you need to use at least 3 or 4 needles. Some patients for certain conditions, especially the neurologic conditions, may use up to 8 needles for an individual infusion, which of course sounds extreme, but based on manufacturer recommendations may be necessary. We can also adjust the thickness of the needle and the depth of the needle. So if we're not getting quite deep enough into the subcutaneous tissue, we may not be getting efficient absorption. So sometimes going a little bit deeper ultimately leads to a more comfortable infusion. Next would be this local site reaction. So this is most commonly what I would just say is an infusion reaction. It is histamine related to sticking the needle into the injection site. So a little bit of redness, itchiness, or a small bump at the injection site. This is something that we can fix with a couple of common strategies, making sure we're rotating injection sites, using an application, using an infusion planner that tells you here's where I did my last infusion. So you make sure you don't rotate back through to the same site, especially if you are limited. If you can only infuse on the stomach, we really want to make sure that we appropriately utilize those quadrants. Dry priming is something that I see a lot, which is where patients are, or rather dry priming is the appropriate way to prepare your infusion. Some patients, they think that you need to be pushing the liquid all the way out through the tubing and see a little dot of liquid at the tip of the needle. That's actually incorrect. I know we think of that from a vaccination standpoint of the doctor. Everyone's seen it in the movie. They press it up, they flick the syringe to get the bubbles out, and then they do the injection. But with these IG infusions, the medication, it actually can burn your skin. And so if you are wet priming the needle, then ultimately you're exposing your skin to the infusion liquid, which then sits there for an extended period of time while you infuse. So making sure that we're leaving about a ½ inch to an inch, just a little bit of space between the tubing and the needle of just that tiny, tiny bit of air is actually the safest way for you to complete these subcutaneous infusions. And then otherwise, just a little bit of Benadryl or some Zyrtec, any kind of antihistamine does a great job at preventing these as well. Next, needle discomfort. Most adult patients need a minimum of 6 millimeters just to break into the subcutaneous tissue. So a 6 millimeter needle is typically designed for pediatric patients all the way down to 3 millimeters for the 6 months olds, the really, really young patients using these kinds of therapies. So an average adult is going to use anywhere from a 9 to 12 millimeter needle up to a 14 millimeter if necessary, just depending on the infusion site and the patient. But managing that discomfort, we can add some Emla cream is really common for patients. It's a mixture of lidocaine and prilocaine that you place onto the infusion site. Just rub it on about 30 minutes before you infuse. That'll numb the area. You can use a cold pack. We actually have some Realo cold packs that we send out as well. It's just a little gel pack you can put in the freezer, and you hold on the infusion site about 5 to 10 minutes before you infuse. Cools the area. Ultimately, you feel less of that pinch. And then if that needle is too long, if you do actually break into intramuscular space, what that will present as is a very deep burning feeling underneath the infusion. It's very obvious and different from the kind of pinch feeling that you get when you first stick the needle in. So it's a very deep, dull burn if your needle is too long. If it's too short, then we're looking more at some of those infusion site leakings and the really superficial infusion site reactions, as I spoke about in the last slide as well. And just in case y'all don't know, there are a couple of different needle brands that are available. Some patients like certain ones, they're cut slightly differently. There's a little bit of variety in them. So sometimes you can switch up the brand and see if that helps you out as well. And then we've got long infusion times. So this isn't necessarily a side effect, but we felt it was something that's important to speak about because not a lot of patients know what actually goes into causing their infusions to be longer or shorter. We of course know if you've got a higher volume of medication we're infusing in you, that will ultimately take longer. However, most patients utilize what I call a static flow rate system. So they've got their medication drawn up in the syringe. It connects to a single piece of tubing before it goes onto the syringe, onto the needle sets, And that singular piece of tubing, that's the go-between there, actually controls the bulk of the flow of the product into your body. So there are different numbers. You can adjust those up or down depending on side effect and individual patient need. And some of you may use what's called a versa rate set. So you can have that little dial that you twist from number 1 to 10. 10 goes really fast, 1 goes really slow, and you can adjust it on your own. Most patients, I believe, like to use just the static, but if you're someone who likes customization and who wants to fiddle around with it a little bit, there are options where you can play with those numbers and see what works best for you. And ultimately, then you can also increase your total needle count. So the more needles means less going into each site at a time, and that ultimately increases the flow rate because it's all going from the big tube down to the little tube, and then it branches out much quicker, so you can decrease time like that.
How many needle sets, how many needles can you get? Up to how many?
So it can go up to 8. However, some manufacturers, depending on the drug, I think if I'm thinking correctly, Cuvitru, for example, limits you to 4, right? So some might limit you to 4. They say this is what we've studied. It's 4 needle sets. That's the max we'll let you have. But you can go up to 8. And there's a little calculator I personally use that helps me decide that when I'm speaking with a patient for the first time. So I can plug some numbers in and say, if I put you on a 2 needle set at the F900 flow rate for a 10-gram patient, you're looking at an 1.5 hour infusion. However, if I put you on the 4 needle set, I can go up and flow rate a little bit, and maybe we're bumping you down to a 45-minute to a 1/2 hour infusion. So,
which is what I do. I have 4 needle sets.
Yep.
I'm debating if I can get 6. I could spread the wealth, so to speak.
Yeah.
I'm taking about an hour now.
Yeah. Okay.
Yeah, one of our goals is for primary immunodeficiency, for treating that on sub-Q, is certainly less than an hour. We don't want it to go much longer than that. Neuro conditions usually double the dose, so under 2 hours is kind of our goal. However, if we can go faster, we want to give you that time back, right? And there's, as Brady mentioned, there's numerous ways. Another additional way too is the 26 gauge needle is kind of the most common and the standard to start with. There is a 24 gauge that is a little bit wider, so it allows more flow, and that will also increase it without going up on number of sites. So,
and this is a great point as well, that this is extremely, individualized. It's one of the most customizable portions of the patient experience. The doctor is going to ultimately tell us what dose we have to do, but we can help figure out how fast we can go within the means of what the manufacturer tells us we're allowed to go within as well. So, you watching there at home, you may say, well, I'm going an 1.5 hours, but I like it. I like going slow. I put on my Netflix, I eat a little popcorn, and I enjoy my time. It's really just a lifestyle choice as well. And some of us, will want to go as fast as possible. And if you've had side effects one way or the other, this is all something that you as the patient, you get to choose. So it's a great point.
One other thing that I'd like to add is that if you get too many needles, it can become too complicated to all the tubing, and it's almost like an octopus that you're stuck in the middle of. So I've seen a few patients that liked 2 and they wanted 4, and then they tried 6 or 8, and they basically went back to something more in the middle because it was too complicated to get everything primed or not primed appropriately and then get it in. So but I think that Will and Brady's concept is they're going to customize what you need for each patient. So if you were a kind of person that could live with 6 or 8, then I'm sure they'll try it if they think that's appropriate, but not very many people can handle that many.
Someone can handle it, Bill. That's for sure.
Not a problem.
That's true.
So I just like to, at this moment right now, it's about 15 to 5. So good, perfect conclusion. I was going to say it's about time for Q&A, but you're right on. You're beating me to the point, so go ahead.
Oh yeah, of course. So again, just to conclude, we've seen there's a whole, family of treatments here, medical conditions, different drugs we're using. As Mike pointed out, our goal here is to try and really individualize care. I think that's what not only, makes just for a good experience from our pharmacy, but you should be considering that for yourself as a patient at any pharmacy, at any doctor, that they're individualizing care for you and making sure that we understand your goals for therapy. This care coordination, we're often a middleman. We are coordinating with nurses, we're speaking with your caregivers, we're speaking with doctors on your behalf. So making sure that all these members of the care team understand your story and your goals is just really important, for you as a patient, just to make sure that you're getting the best and the highest quality care that you can be. Understanding that, you should not shy away if you are experiencing these side effects. I've listed a lot here today. I've listed a lot of ways for us to help fix them as well. So, some patients, I can't help you if I don't know what's going on for you. So that is really important for me to hear. No pharmacist is going to rip the IG out of your hands. We're really trying to make this something that's comfortable for you, so that you continue to stay on therapy with us long term and that you have a great quality of life. So we want to help remove these barriers and ultimately just make for a better patient experience. So that's really, I think, our goal here.
Well, thank you both. I'm looking to see if there's any questions right now. I see it shows me that a couple of hands are raised, but I don't see any questions posed. So if anybody of the attendees online have any questions, please send them to me so we can ask them to the group. I know there are 2 attendees in person. Do you have any questions you want to continue to ask that we either already started or that have come to your mind since you asked the first ones?
Is there a recommended best time to infuse?
That's a good question.
Because I do Monday for a reason, because if I have a down day, flu-like symptoms, I want it done early in the week so it's not messing up my next weekend.
Yep.
Okay. And sometimes I'm down, but that's it. It bounced back about a day.
Yeah.
Okay.
But best time of day?
It is kind of patient specific. We recommend a lot to our patients in the evening. If it's in your case for sub-Q when it's self-administered, sometimes some of those side effects that may occur early on, and then you're sleeping through it. So it's you're truly not as affected by them. Really, what's important is what works for you, and then making sure you're consistent. So if Monday works for you, it's every 7 days or every 14. To make sure that you're staying adherent. But we have found that usually kind of that nighttime routine, especially for sub-Q, is ideal.
Okay.
Is there any type of nutrition that you guys have found or have any studies have found to be more beneficial around the time of the sub-Q?
Or something to avoid?
Yeah, so like has anybody ever studied is a diet high in protein or high in carbs or low in fat or whatever around that time more conducive to reducing the side effects?
So I would say having something in your stomach before infusion, whether it be IV or sub-Q, I always tell patients just have a little something on hand. It's more important for IV from a nausea standpoint that they tend to feel better, but from more of what you're getting at, avoiding really salty foods, that's where it's coming in with the hydration as well. Even though sub-Q you're affected a little bit less. I'm sorry, I'm not trying to get anyone in trouble, but avoiding anything that's really going to dehydrate you significantly is what I would say, just because, again, that can just make you feel a little down. What's in these IG products? We know there's IgG, there's trace amounts of sugar, there's trace amounts of salt in most of these products, and ultimately that's going to draw some of the liquid away from us and cause that additional dehydration. So that's where that piece plays. And I don't know much about a keto diet, carnivore, whatever, if there's any other studies than that, though.
I'm not sure of that either.
Yeah.
I mean, I would just echo what Brady said is the dehydration is a large issue, and a lot of that results in a headache that can occur usually during the infusion or post for 24 hours, 48 hours. And to prevent that is to drink, stay hydrated the day before. We recommend that the day of, the day after. As much as you can, but that is the goal.
Worst thing, I don't drink a lot of water.
And it's tough sometimes to remember, but we certainly understand.
So, but one of the things that I think the question that she just asked is maybe not so much to do with the actual infusion, but thinking about some kind of an anti-inflammatory diet. And obviously the I in CIDP is inflammatory neuropathy, which is not that kind of inflammation, but we have a lot of patients that are trying to optimize their diet, and we sometimes connect them with our dietitian to try and figure out, but in many cases, the diet is optimized individually because not everybody can tolerate either eating more of this or less of that or whatever it may be. And then of course there is the possibility of taking supplements and vitamins and things like that many people want to take in addition. So that would need to be something consulted with either dietitian, or I have a friend who's a naturopathic physician. And so when I talk to him, I'm quite amazed at what he thinks is an important, appropriate diet, even though probably nobody would be happy to eat it. But so that's a problem, and that is whatever you do has got to be sustainable, because you're going to be trying to do this, day in, month in, month out. So right now I don't see any other questions, but I wanted to ask, I think what's really important for me, and I want to see what Will and Brady feel about this. I frequently advise my patients to understand more and more about the world of IVIG, almost as if it's a barrel of oil and we're talking about OPEC. And the fact is that there could be shortages, there could be issues if you change insurance. So a lot of patients, like the one I just mentioned before we started, when you change to Medicare, or if you decide to quit your job or get a new job, you may have a new insurance company. So, but I'd like to ask Will and Brady, how it's been there on the East Coast. I know on the West Coast, we have a lot of patients that get themselves in trouble because they make changes to their insurance or jobs or other things, and then they don't realize the consequences that may come, that they may have something to do with. But then there's the ones that are completely out of the control, like a shortage of a drug, or you can't get 20-gram Gamma Guard liquid or something. All of a sudden, that could be an issue, or the drug may be recalled for some reason or lots. So I think a lot of people don't, once they get a standard regimen, they're happy. It took them years to get there. They're getting better. And then the next thing you know, some nuance, and I call it the pharmacoeconomics of IVIG, and that is very similar to a barrel of oil with OPEC, that is trying to keep the prices high, trying to have some sort of, monopoly on the products and things like that. So how have you guys had a lot of issues like on the East Coast, like I see on the West Coast?
That's a great question, Mike. A lot to unpack. So I think there were two things in that I understood. So kind of the allocation, making sure that if I'm on an IG product, then I'm able to supply that product, infusion after infusion, month after month, without running into any drug shortages. And then there's the insurance piece too. As we age or change jobs, we may run into commercial to Medicare, or commercial to a different commercial, depending on the employer. My wife, for example, in January, is starting a whole new insurance group with her company. She has nothing she can do about it. So, now we've got to find new providers that are in network, those type of things. What do you do when everything was working well? So the first part of that, with allocation, I think Brady and I and our pharmacists are constantly researching this. We have great network with our wholesalers, with our manufacturers, constantly asking, what's coming up, what are updates. We are meeting often with a lot of these groups that supply these medications, so that we are in front of it. Throughout the time we have seen allocation issues hit, we've been lucky enough to secure enough immunoglobulin ahead of time to get through these allocations and not affect our patients. So in a perfect world, that's what we try to do. If there are allocation issues, of course, we're kind of going back to a lot of things that Brady went over, and looking at the different brands, making sure that they still line up with your health condition. And if we have to switch, we go through that approval process with patient and provider. And so we have seen them. We've been lucky enough that it hasn't actually affected our patients here at Realo. On the insurance side, there's a lot to consider. Commercial payers have formularies, and so we're constantly looking at those. We're in 14 states now, and so we have 14 different Blue Crosses and 14 different local Aetna plans and those type of things. And so there's certainly a lot that we research and educate, and making sure that we know, because what Blue Cross North Carolina may be is different than Blue Cross of Texas, right? And so we're constantly monitoring those things, because as I mentioned earlier, we want to get it right that first time when we submit. And then when we travel into Medicare, by the way, October 15th to December 7th is the open enrollment for Medicare. So if you haven't started asking your pharmacist, go ahead and start asking your pharmacist about those. The plans are out, they're available. We can look at them, we can see what formularies are out there if you're on a particular IVIG or sub-Q IG, we look at that. And so you'll want to sit down with your pharmacist and go through your medication list, not just what's on your IG. You want to, if it was being paid for by Medicare, B as in boy, like Brady said, we want to make sure we have that supplement in place. What's the right supplement? We're looking at out-of-pockets, so what you're paying on that monthly premium, and then what the deductible will be at the beginning. So, a lot of times there'll be a $450 or $500 deductible. Sometimes if you're lucky, other times it's $2,000. And then there's a max out of pocket. So is it $5,000 or $10,000? It all depends. And with Medicare D, as in dog, if your medication goes to that particular drug plan, or it all depends on diagnosis and condition a lot of times. Some PI, primary immunodeficiency diagnosis, some go to Part D, some go to Part B. Nearly, and this is in the home setting is what I'm speaking of, and nearly all neuro go to D as in dog. And so what we're looking at there is very similar. What will your copay be? What will your monthly premiums be? What will your out-of-pocket and deductible? There's some changes coming in 2024, and then it's changing again in 2025. At Washington, they've got some few things going through. 2024 with Part D, they got rid of the donut hole, or the Medicare gap. IDF has a great IDF, Immunodeficiency Foundation, has a great explanation of the changes that are coming. But essentially, they got rid of that not catastrophic, the Medicare gap or donut hole. And so you have a deductible, and then it goes straight into that 5%. And so it will bring it down, but if you're thinking about thousands of dollars, 5% is still high. So I say all of that is to make sure you're working with your healthcare professional. If you don't have someone who can look that up, we can certainly provide that. We have nurses as well that are plugged in different states that are specialized on the commercial side. And so we get our patients contacted with them, and they're able to navigate those nuances as well, and look at a lot of those. Sorry, Mike, I know that was a lot, but I hope I hit it.
That was perfect. That you proved my point that whenever there's a change, you need 6 months to plan it, because there's so much that could be involved, and God help you if your diagnosis changes. Is there any other questions from any of the in-person attendees?
I have one more. Well, two things though. First, I just want to say thank you. This has been really helpful and informative. I really appreciate it. Will, Brady, you guys are awesome, and all the support that you've given Bill over the past several years since he went on the program. So I, as a caregiver, really, really appreciative of that. My actual question is the presentation. Will you be providing that? Because there was one slide, Brady, you were talking to that had a list of a whole bunch of organizations and their websites that I would be very interested in getting.
Please, yeah. Mike, I believe we are, but I'll let you answer.
So this will be published on the ADA. It is godoada.org is the website. It will be on there and on their YouTube channel probably by tomorrow night. So you can find it there. And then also once it's available, then we'll probably make a copy available to the Realo team through Will. And so you can get it either from him directly in a couple of days, or you can log into the ADA website as soon as like tomorrow night or so, maybe Thursday morning, and you can see it there.
Thank you.
Okay.
Do you guys prefer who contacts who about issues?
Like if y'all were to call us?
Oh, I send emails. I'm on email all the time.
Oh, yeah, true, yeah.
If I have an issue about the needle sets or something like that, does it matter? If
No.
I flood you guys, you'll get it where you need to get it, right?
That's right. Yeah.
Okay.
Keep doing what you're doing.
All right. Super.
All right. Any questions we have 2 attendees on the webinar. Any questions from them? I don't see any hands or questions, and both of them are on mute. Let's see if I can unmute them. I can't. They're self-muted. Okay. So either of the 2 patients that are online want to ask any questions? All right.
Yeah, I would love to ask a question. Just if a pharmacy's out of network, does that mean that they can't help me with my in-home infusions? Can you explain what that means and what you specialty pharmacies do to help those patients out?
Sure. We engage in this a lot with out-of-state patients. With commercial plans specifically is what I believe he's discussing. So there's of course in-network and then out-of-network pharmacies. A lot of times when that happens, benefits do change. And so what I mean by that is your max out-of-pocket in-network may be $5,000, and then your max out-of-pocket out-of-network may be $10,000 or $15,000. A lot of times it just doubles, but they're all a little bit different. Some don't have any out-of-network benefit at all, and so you're really kind of forced to use that in-network provider. When we engage with patients like that, of course, we don't want our patients to have a out-of-pocket that would vary from in-network or out-of-network. A lot of our patients were able to get full assistance.
Well, can I stop you a second? We're down to 14 seconds here, and I don't know what's going to happen at the end of 14 seconds, if we're going to get disconnected. But they may keep going. There's 6 seconds left. Let's see what happens. If it stops and we all go away, then you can continue answering the question. Okay, it's passed, but it's still going on. Okay, so I just didn't want you to be in the middle of it and not realize it's going to stop. So
No worries, it's a good question.
Finish your answer there.
Y2K all over again.
Yeah.
No, so yeah, to finish that, we're looking at those out-of-pocket. So when we do those benefit investigations, this is where we discover this. We have these open conversations with our patients and let them know that this is what the funding is available. Nothing will change with you, because a lot of times we build these relationships with patients, we build these relationships with our providers, and they trust us. And so they're recommending the patient, newly diagnosed patient, they know that they can speak with Brady and get this level of education, get this level of comfort, which will ultimately increase their quality of life. And so we're going through on the financial assistance side, start to finish, finding these copay assistance programs, and nearly most of the time, we're going to be able to cover all of it 100%. And when we can't, we're upfront with the patient to let them know. And if they choose to go with an in-network provider, I understand. And we kind of do a smooth transition and find one that works for them. I hope that answered your question, but ultimately we're looking at those manufacturer assistant programs to keep those costs down. And 90% of the time we're able to do so without a change in anything.
So I think that's a great answer. And the only thing I would add is that it used to be that out-of-network was a little bit easier to deal with than it has become recently. And one of the things we try to do, and I'm sure that the Realo team does the same, is when a new referral comes in, we already know if we're in network or not, and we've already tried to, our first job is to do the right thing for the patient. And if there's another pharmacy that's in network that's going to minimize your out-of-pocket and make it easier and more affordable, then we want to make sure you know about that, even though your doctor may have referred you to our pharmacy, either the Realo one or the one that I represent, which is Kava Fusion. But I think that the problem is a lot of times the patients don't know what's in network and out of network until they get a prescription, and they probably never got a prescription for a drug that's $100,000 a year or more before. So they really are not, they're surprised when they figure out what's going on with their insurance company. So I think Will's answer was perfect. Try to optimize it for the patient, and if it isn't Realo for some reason that can do it for you, then they'll warmly transfer it to the right company that can do it and make it most economic for the patient. All right, any other questions online right now or in person?
Yeah, I have a follow-up question. Sorry. Thank you for that explanation. That was really helpful. Can manufacturer assistance programs help me if I'm out of network, though?
It does depend on the manufacturer program, but for the most part, the answer is yes. They're treating you as the patient and not the pharmacy.
Yeah, so what happens is that you may qualify, as Will said, it's complicated whether you're on the drug already or never been on the drug, and also many times has to do with your level of income compared to the federal poverty level. And then if the financial assistance group knows that if you went to, say, Blue Cross of North Carolina, you'd be in network, and if you went to a different pharmacy, they have a contract, and they may help you see a clear path to the least economic output for you. But it's complicated, and so it sounds like the Realo team is doing exactly what I'm used to doing, that is looking at every possibility to figure out how the patient could be brought on service. What happens if we do it? What happens if somebody else does it? And what's the patient's real out-of-pocket going to be? And will the other company be able to meet the needs of that patient versus what we at either Realo or other companies can do? So it's complicated, and that's why it took me a whole board to fill up the explanation of what's covered where, and even that was not complete. So so at this time, I'd like to conclude then. I'd like to thank Doctors Holland and Hecht for being with us this evening, taking time to educate the community. Thank you for the audience for tuning in and staying with us to the end. Please take a few minutes to fill out the quick survey, which is online for you folks that are online. And if you enjoyed today's presentation, please consider making a tax-deductible donation to ADA, which you can find on the website where the video will be recorded. And so I'd like to say this is Mike Regas, and we're going to sign off for tonight. And it seems funny, after Will and Brady and I and Warren, who's the executive director of ADA, and I have talked probably 20 times along with Coy to set this up. It went off without a hitch. And I'd like to congratulate all of us for making it work without a hitch, and you guys for all attending. So thanks, everybody. We'll talk to you soon.
Thanks, everyone.
Thank you.
Thanks, Mike.
Bye. Bye.